So the next case will be presented by Dr. Ashraf Amin, Professor of Gastroenterology at Shams University.
شكرا دكتور وائل والشير بيرسون الموجودين، وشكرا لزمايلنا اللي موجودين. Okay, we are going to present one video case, ERCP case, which is a non-functioning migrated biliary metallic stent causing gastric outlet obstruction. This 55-year-old male patient presented to our hospital with history of CA pancreas and obstructive jaundice, and he had biliary metallic stent done by BTC with no any trial of ERCP. And the patient presented to interventional radiology, or he referred from gastroenterology to interventional radiologist directly to do BTC, which is not understood, but the procedure was BTC and insertion of metallic stent. After the procedure, the general condition of the patient was deteriorated, and the jaundice was increased together with symptoms of cholangitis and persistent vomiting due to obstruction. So we did ERCP on an emergency base due to the cholangitis and obstruction. Okay, this is the we found this view on in the ERCP. So the stent was migrated, and it's to the duodenal wall, and it was impacted. So there is obstruction, and this stent is non-functioning because the bilirubin was increased and the patient had cholangitis. So we tried first to solve the problem. This is the X-ray. The stent was migrated and impacted in the duodenal wall here. So what I did is, so I cannulated, so this is uncovered stent. So I cannulated through the uncovered stent, and I passed the guide wire. Then I inserted a plastic stent. So this plastic stent was inserted through the wires and through the wire of the metallic stent, and we inserted plastic stent to resolve the cholangitis. So the decision was to bring the patient again to solve the problem, which is a migrated stent. So this is the common bile duct, and this is the duodenal wall, and the stent is not reaching above the stricture. In the same time, it's impacted in the duodenal wall. So the idea was, if somebody knows when we have migrated gastric band for obesity, when it is invading the gastric wall, we pass the guide wire through this gastric band, and we cut the gastric band through the scope. So this is the same, I use the same idea. So I inserted a guide wire. Then I tried to make loop around the stent in the middle. So this is a guide wire. I passed below the stent, the metallic stent here. Then I inserted a snare, and I catched the other wires, the wire. Then I make loop around the stent by pulling the wire through the snare. So this is the wire now, guide wire, around the middle of the metallic stent. So this is a wire. I made a loop around the metallic stent. Then I pull all the taraphenal wires through the mouth of the patient. So this is the stent here, and I put the wire here and take the both ends of the wire from the mouth of the patient. يعني أنا عملت loop around the metallic stent, I took the two loops, two ends of the wire through the scope. Then using a Sohandra lysotripter, I put the two wires inside that lysotripter, and I cut, using the guide wire, I cut in the middle of the metallic stent. This is a video. I just first make presentation what I did so we can understand here. So this is the metallic stent. This is the plastic stent inside. First, I tried to move the metallic stent, but it was really impacted in the duodenal wall. So I afraid that there may be some maybe perforation happens, so I stopped. You see the stent here, migrate stent. This is the duodenal wall, and this migrate stent from the papilla. So I catch the metallic stent, it did not move, so I afraid to make a perforation, so I stopped. So I buy sphincterotome above or below the stent, then I put the guide wire. And this is done under X-ray, of course. This is a guide wire. I was above the stent, then I put the snare and take the other end and pull both of the end outside the patient. It's uncovered. Maybe partially covered because this is the hole here. I made the hole here. It's even if it is covered, you can penetrate it. Yeah. And it is fully covered, because and the question here why he did through the intervention radiology before ERCP. And from the beginning, he referred to intervention radiologist. That's why we prefer rendezvous technique. Even if we can bust it, we can see the papilla, we can see where to insert the metallic stent exactly, or ERCP.
Sometimes during rendezvous, the opposite occurs. The stent goes inside and maybe sometimes outside the liver.
Of course, and because I discussed with the intervention radiologist, he told me it's better to do everything. He wants to do everything. So I told him there is a rule of rendezvous. Number one, before putting a stent, you have to do sphincterotomy to avoid pancreatitis. And when we put plastic stent or metallic stent, it's better to do sphincterotomy first, so that you avoid especially if it's covered stent or plastic stent. So this is a guide wire now. I succeeded to put the guide wire, and there is a the wire is looped around the stent here, and I'm grasping the two ends outside the patient. So now we see the wire is looped, and I take the second, the end by snare.
Can we advance the video, Dr. Ashraf?
In 2 minutes.
Okay.
So now the stent is looped. Then I cut with the Sohandra. So I separated the two stents in the middle. The stent in the middle is the two halves. Now the stent is cut here. السtent دلوقتي اتقطعت نصين بس عشان البليدنج because of the bleeding is not very clear. But تسرع الفيديو شويه. مش هتسرع؟
مش مشكلة.
Now the stent is cut in the middle into two halves. Half in the duodenum and half in the papilla. شلتها, but it was easier to be removed by the snare when you can see it. Okay, more. نكمل. سرع. تمام. بس كده. Stent was the second step is that I put another metallic stent. على بس خلاص سيبها لا سيبها ليه بقى شغال. Okay, this is the second metallic stent. No, inside the
inside the rest of
the side
the remaining half
the other half
of the
metallic stent. So I put metallic stent under vision. I did not remove the plastic stent. I removed it at the last step because this makes the access easier for me. So I can see the metallic stent and I can put the wire easily. I don't remember, but maybe partially covered. I removed with a snare. It was easier. Yeah, not it was impacted, but easier to be removed with the snare. Because you are pulling with the foreign body forceps, you cannot يعني ما تقدريش تحكمي بالظبط ممكن يحصل perforation. But with the snare you can hold it. So this is the second step here. Second stent is done here, and there is bus coming. By this technique, you can use the guide wire for ERCP to cut anything. If the gastric band invaded the stomach, you can put the guide wire and cut it with Swander technique. Sometimes we see this if you're doing many ERCP, you can see this metallic stent migrated very common, especially if it is done with intervention radiologist. Huh? Swander? It's very cheap. You take the wire, you put it in the catheter, and you crush it like stone. This is the stent here in a good position. And the other piece of the stent I removed with a snare. Thank you very much.
Thank you, Dr. Ashraf. It's a really interesting and very nice case. You faced a problem that you solved with a good idea. Thank you.
Thank you so much, Dr. Ashraf, for reading this nice case, nice demonstration. And I really like the pre-plan that you drew, the plan that you drew on the paper. Yeah, it was really illustrative. Thank you so much.